the cardiology station, the one that everybody dreads. But I'm going to tell you how to pass first time and some tips and tricks along the way. So stay tuned. So the cardiology station, you walk in, the examiner looks at you and says, I want you to perform a cardiovascular examination on this child. Step 1 of the examination is what we call wiper. All right. So the W stands for wash hands. I stands for inspect your surroundings and introduce yourself. P stands for pain. So ask the patient if they are in any pain, or ask the relative that's with them. And also stands for permission. So ask the patient or their relative for permission, and also talk about adequately exposing the child. So specifically for teenage girls, that would be asking them, if it is cardiovascular station, that part of the examination will require you to remove your top, and we will cover your modesty with a towel, and the examiner is here as a chaperone. Is that okay with you? And hopefully they will say yes. E stands for exposure, adequate exposure. You want to make sure that for the cardiovascular exam, the entirety of the chest and the arms are exposed. R stands for reposition. So make sure that the bed is at a 45-degree angle, because the examiner will be marking you for that. Step 2 is looking for features of dysmorphism. So in the cardiology station, syndromes that will have dysmorphism will be as follows. Trisomy 21 or Down syndrome, and you're looking really for facial features. Turner syndrome, so you're looking for a sort of short stature, a webbed neck. Once you expose the chest, you're looking for a shield-shaped thorax, widely spaced nipples, a low posterior hairline. Williams syndrome, so Williams syndrome, you might notice the sort of stellate-shaped iris. You may notice that they have a sort of elf-like ears or elfin ears, low-set ears, and you might also notice a sort of happy disposition to them. Yeah. And the other syndrome would be Noonan syndrome. So again, you're looking at a shield-shaped thorax and a slightly short and webbed neck. But of course, Turner's syndrome is only in girls, but Noonan syndrome can be in both. Next step is to look at and inspect the hands. So what are you looking for in the hands? Well, start off at the distal end, so looking at the fingertips. You're looking for any evidence of clubbing, any evidence of peripheral cyanosis. You're looking for signs of endocarditis, Janeway lesions or Osler's nodes. Then you want to palpate the radial pulse. And also when you're palpating the radial pulse, you want to look for any cardiac catheterization scars that the child may have had. Once you've palpated the radial pulse, you should palpate it for approximately 10 seconds. You should also do it on the child's left hand. Once that's done, what you should do is again just confirm that that the child does not have any pain in their left arm, and then raise their arm above their neck, and what you're checking for is a collapsing pulse, which is a sign of aortic regurgitation. The pulse volume will drop as you raise the arm. You should then also palpate the pulse, the radial pulse on the right, at the same time as the pulse on the left, and you're looking for radioradial delay. And that can be a sign of coarctation of the aorta. The next step is to palpate the brachial pulse. Again, you should ideally do that with the thumbs on both sides, and you should also ask for the blood pressure and the height, because you will need the height to chart the blood pressure for the appropriate centile. Next step is the facial examination. So in the face, you're looking for the eyes. So starting off, is there any conjunctival pallor? Then moving on to the lips, is there any central cyanosis with the tongue? Now the tongue is the most important thing. If the tongue has central cyanosis, it probably means that this child has had cyanosis for a long time. You may also notice the condition of the teeth, and that will be very important to comment on as well, the condition of dentition within the child. What you're looking for with the teeth are any signs of dental caries, also commonly known as cavities forming, because they can be a risk for endocarditis if the child has had any native valve surgery, more common with mechanical valves, but even with some of the bovine or porcine valves, sometimes it is an elevated risk. So next, you're going to look at the neck. You'll ask the child to look over and expose the right part of their neck, and you'll ask them to lie back at a 45-degree angle, and then you can calculate the height of the JVP, the jugular venous pressure. So the way you do that is when the child is lying down, there will be some vibrations of the external jugular vein, and you should measure from a horizontal line where that pressure is compared to the start of the sternum, so the angle of Louis. And that measurement in centimeters equates to the pressure. About 3 centimeters is normal pressure. 4 is moderately increased, and 5 centimeters and above is significantly increased jugular venous pressure. So next step is inspecting the chest. When you inspect the chest, again, we're inspecting it not just for dysmorphism now, but also for any scarring. You may notice a midline sternotomy scar. You may also notice in the side thoracotomy scars, which could be either side, and you may also notice some chest drain scars. Those will be typically a bit more inferior. So in my free clinicals guide, in the cardiology section, I have listed the operations that the child would have had to create those scars. Then, once you're done, you need to palpate the apex beat. To palpate the apex beat, palpate both on the left side of the child and also on the right side of the child, because you want to make sure that you do not miss dextrocardia. All right? It is very common in the clinical examinations to have a child with potentially dextrocardia as one of the signs. Once that's done, you move on to auscultation. And when you auscultate, you want to auscultate in the 4 areas, so the right upper sternal edge, the left upper sternal edge, the left lower sternal edge, and the apex. You will also have palpated at that point for any heaves, indicating left ventricular hypertrophy, and any thrills, indicating a significantly loud murmur. But when you auscultate at those signs, really try and hone in on where you feel that the murmur is the loudest, if there is one. Occasionally, on auscultation, you will also hear the sounds on the right side of the heart more clearly. And if that correlates with, again, the apex beat being on the right, you can confirm that this child has got dextrocardia. And a pro tip is approximately 50% of all congenital cardiac conditions have got a ventricular septal defect. So if you hear a murmur in the apex or the lower left sternal edge and it's pretty loud, or you can hear a murmur everywhere, all over the precordium, and it's very loud, the likelihood is that this child has got a VSD at the very least. You should also auscultate for radiation. So that means auscultating at the neck, typically the left side of the neck, which will radiate some aortic stenotic murmurs, and also auscultate the lung bases. And what you're looking for is crackles or rales, which will be a sign of pulmonary edema, typically in a cardiac station, signs of cardiac failure. But you may get a build-up of rales or crackles, especially if the child has got dextrocardia, because that may be Cartagena syndrome. Cartagena syndrome is dextrocardia alongside primary ciliary dyskinesia, are more prone to bronchiectasis, and therefore they may develop infiltrative fluid within their lungs, which you will be able to auscultate at the lung bases. Next step is palpating the abdomen. So what you want to ask them to do is relax back at 45 degrees and just have a look at their abdomen. Ask them if you can drop the bed down to completely flat, and if they get breathless. If they say that's fine, then bring them down flat and palpate the abdomen. And what you're palpating for specifically is just hepatomegaly. So this is not an abdominal examination, you're just palpating for hepatomegaly. And what I also do is I also percuss for hepatomegaly. So you want to percuss the lower and the upper liver edge, and then you will have an idea about whether there is hepatomegaly. Hepatomegaly in a cardiac lesion is almost always indicative of cardiac failure. And finally, you end by examining the ankles for any pedal edema. And again, that would be indicative of cardiac failure. You thank the patient and the relative for allowing them to examine the child. And then you turn to the examiner and say, to complete my examination, I would like to take a full history and palpating for the femorals, taking the blood pressure and height and plotting the height, weight, and blood pressure on an appropriate growth chart. So that's the examination. Now, what can they throw at you? What cases commonly come up? So, as we mentioned, one of the things that is likely to come up is a murmur. Now, if you'll have a look at my free guide on the MRCPCH clinicals, in the cardiology station, I have mentioned where different auscultatory findings suggest which murmurs. Then you may have a water-hammer pulse, which would be indicative of aortic regurgitation. You may also find hepatomegaly and a median sternotomy, and that almost always is indicative of complex cardiac surgery and current cardiac failure. You will also find different scars, and again, in my free guide, I've explained what the different locations of the scars mean in terms of different surgeries. And finally, as we mentioned, if you have dextrocardia, please think about Cartagena syndrome, especially if you can auscultate rales or crackles at the back. Personally, that's the case that I got in my clinicals, and because I had this thought in my mind, I was able to elicit the correct diagnosis. Now, after the examination is finished and you have presented your findings and you've given your differential diagnosis, the examiner will typically ask you two questions. The first question is, what investigations would you like to do on this child? So the way that I break it down, very simply, is bedside blood tests, imaging, and special tests. So, bedside tests, height, weight, forelimb blood pressure, pre- and post-ductal saturations if the child is under 1 year old, and also an ECG. Blood tests should be urea and electrolytes, calcium, magnesium, and a full blood count. And the reason for that is because you have electrolyte disturbances which can cause arrhythmias, and that are associated with certain syndromes, for example, hypercalcemia in Williams syndrome, and also a full blood count because at times you can get a flow murmur with significant anemia. Imaging, so we would like to request a chest x-ray. A chest x-ray would be useful in defining whether there is cardiomegaly, whether there is a plethoric lung field, which can be the case in certain cardiac conditions. And of course, the definitive diagnosis would be provided by an echocardiogram. And some children may or may not require a CT angiogram to look at their pulmonary arteries and their coronary arteries, both of which are poorly visualized in echocardiograms. The final question the examiner will ask you is, okay, how would you like to manage this child? And again, we break this down into 4 sections. Acute management, which is always an A to E assessment of the child, and in the case of cardiac, oxygen if needed, and diuretics if needed. Next, we move on to the chronic management. Chronic management includes the MDT approach with some of the following members. So the local pediatric cardiologist, perhaps the cardiothoracic surgeons, each hospital locally should also have a local paediatrician with an interest in cardiology, which can take care of these children long term, so we should involve them. These children also often need dietitian reviews because their weight is often poor, because their body is using all those calories that they have, is using extra calories in fact, because their heart is having to work harder. If there are any dysmorphic features, of course, we would require a referral to genetics, so the geneticist. And if you really want to impress the examiners, all children with chronic conditions are able to get open access to their local paediatric ward, which means that they just need to phone up the paediatric assessment unit at their local hospital and say that these are the symptoms my child is having, and they can get instant, at least telephone access, or if the doctor wants, access physically to the paediatric assessment unit. Now, the third stage of management is school and social management. So every child that has a chronic illness benefits from having an education and healthcare plan. So I would say, I would also help the child to create an educational healthcare plan, and also the family has access to a social worker who can undertake a financial needs assessment to give them some financial help. Every child with a chronic illness can benefit from financial needs assessment, and the family may get some extra support, monetary support from the government to help their child. So again, that thing will give you another gold star. And finally, mentioning the family. That's the fourth step of management. I would also involve the family. I would ensure that they knew what red flag symptoms to look for to bring their child into hospital. I would ensure to give them a leaflet on the condition I would ensure to give them a leaflet for the condition that their child has and to answer any questions that they have. And finally, for a gold star on top, I would say to the examiner, and I would like to recommend the online family support group known as contactafamily.org. Now, this is a wonderful website where lots of families that have got children with specific conditions have said that they would be open to meeting up and contacting other families of children with their condition. So this website has collated all of those families and has gathered them under the condition that their child has. So you can search for the condition that the child has, and you can instantly get in touch with another family, and that is the end of the station. So hopefully this has helped demystify a little bit of the cardiac station, and you feel a little bit calmer and a lot more prepared. So check out my free guide on how to pass the clinicals first time, and hopefully I'll see you at the next video. Peace and blessings.